Hey everyone, welcome. Thyroid disease is everywhere, and let's be honest, the symptoms can be all over the place. For us as pharmacists, that puts us in the perfect spot to really help patients figure out their treatment. So think of this as your high-yield clinical briefing, designed to arm you with the essential counseling points you need right there at the counter.
Okay, let's jump right in. We're going to cover the real must-knows. We'll start with the basics, the key differences between the thyroid states. Then we'll get into the core management strategies for both hypo and hyperthyroidism. After that, we'll tackle the super important considerations in pregnancy. And finally, we'll wrap it all up with a practical checklist you can literally use every day.
First things first, let's get the foundation right. At its heart, thyroid dysfunction is really a tale of two conditions. You've either got too little hormone or you've got way too much. Getting this core difference down is the key to, well, everything else we're going to talk about.
And this slide just lays it out perfectly. On one side, you have hypothyroidism. Think of this as the body hitting the brakes. The thyroid is underactive, so metabolism just slows right down. On the other side, hyperthyroidism. That's the body hitting the gas pedal. The thyroid is overactive and metabolism goes into overdrive. Now, here's the interesting part. Notice how the TSH levels are flipped. Let's talk about why that is.
Okay, so TSH. Understanding this is absolutely crucial for patient counseling. Here's the easiest way to think about it. Imagine the pituitary gland is the boss, and the thyroid is the worker. If the thyroid worker is being lazy, or underactive, the pituitary boss has to yell louder to get it to work, so TSH is high. But if the thyroid worker is overactive and already doing way too much, the pituitary boss just whispers, so TSH is low. It's that simple. And that one lab value, it's our master signal for everything.
Okay, now that we've got that down, let's zoom in on our first major category, treating an underactive thyroid. The goal here is pretty straightforward. We need to restore that missing hormone and get the body back into balance.
So, you're at the counter and a patient mentions they're just exhausted all the time. These are the classic clues of a slowed-down system. Now, they're not specific, right? But if you hear someone talking about constant fatigue, feeling cold when everyone else is fine, or changes in their skin and hair, that's your cue. It's a perfect chance to gently ask if they've had their thyroid checked lately. These are the real-world hints we can pick up on.
All right, levothyroxine. This is our bread and butter for hypothyroidism. The goal, as we know, is to get that TSH back to normal. But it's so important to counsel patients that if the dose gets too high, they might start feeling anxious or like their heart is racing. Basically, they'll get symptoms of hyperthyroidism. And you have got to look closely at that key interactions row. This, right here, is where we as pharmacists can truly prevent treatment failure. And seriously, if there's just one thing you hammer home about those interactions, it is this: that timing is non-negotiable. If a patient is taking their calcium supplement with their levothyroxine, it's just not going to get absorbed properly. Making sure they understand this 6-hour rule can be the difference between them feeling great and the treatment doing absolutely nothing. Now let's flip the coin. Managing an overactive thyroid isn't about restoring balance. It's about calming a metabolic storm. Our job here is to help dial down the production of those thyroid hormones and get the symptoms of a body in overdrive under control.
And on this side, these are the red flags for a body that's just running way too hot. A patient might mention they're losing weight but not even trying to. Or they feel like their heart is about to pound out of their chest. Or maybe they're just constantly hot and anxious. These symptoms together paint a pretty clear picture of a system running way too fast, and they definitely need to see a doctor.
So for this, we have two main tools in our toolbox: methimazole, or MMI, and propylthiouracil, or PTU. Now, most of the time, MMI is going to be our go-to. Why? Well, it really comes down to safety. PTU has a rare but really serious risk of severe liver damage. There is one critical exception, though, which is the first trimester of pregnancy. We'll get to that. It's also important to note that both of them can cause a rash or a dangerous drop in white blood cells called agranulocytosis.
And because of that risk, this next point is non-negotiable. This is probably the single most important safety warning you will give a patient starting these drugs. A fever and a sore throat aren't just a cold. It could be the first sign of that dangerous drop in white blood cells. And jaundice, the yellowing of the skin, that could signal liver problems. This warning is an absolute must. Okay, let's talk about a really critical area: pregnancy. Managing thyroid issues during pregnancy is such a delicate balance. The health of both mom and the developing baby really depends on us getting this right.
And pharmacists have a huge role to play in making sure communication is timely and clear.
All right, let's play this out because you know this will happen. Your regular patient, you know she's on levothyroxine, comes up to the counter and tells you with a big smile that she just found out she's pregnant. She's thrilled, but she's also worried about her medication. What is the very first, most important thing that you tell her?
And here's exactly what you do. It's a simple, step-by-step process that you can deliver with confidence. First, you reassure her. Let her know that taking her levothyroxine is not only safe, it's absolutely essential for her baby's development. Then, you give her this very specific instruction. I want you to increase your dose right away. The standard advice is to start taking 2 extra tablets per week. You empower her to protect her pregnancy right then and there without waiting for that doctor's appointment.
Now, when it comes to hyperthyroidism during pregnancy, the script completely flips. We actually prefer PTU in that first trimester to minimize any risk of birth defects that have been linked to MMI. But because of PTU's own risks we talked about, doctors will often switch the patient back to MMI for the second and third trimesters. And MMI is also what's preferred during breastfeeding. It's a key therapeutic switch you just have to remember.
Okay, deep breath. We've gone through a ton. Let's boil all of this down into one final high-impact checklist. These are the absolute essential counseling points that you should be hitting every single time.
Here they are, your top 4. Number 1, levothyroxine. Timing is everything. Empty stomach, 6 hours away from calcium or iron. Got it. 2, MMI and PTU. Reporting fever, sore throat, or jaundice isn't a suggestion, it's a do-it-immediately instruction. 3, a new pregnancy with hypothyroidism? The action is 2 extra tablets per week, starting now. And number 4, a great practical tip. Tell your patients to stop taking any biotin supplements at least 2 days before they get their thyroid labs drawn, because it can really mess with the results.
You know, our job goes so far beyond just making sure patients take their pills. We help them understand the why the timing of their medication matters, why they need to watch for a sore throat. So, the final thought I'll leave you with is this. How can we use every one of these conversations to turn our patients from just passive recipients of medication into active, empowered partners in their own health journey? Thanks for joining me.